Good evening to all of you. I welcome you all to the day 3 of the MD selection preparatory course in family medicine conducted by the Sri Lanka College of Specialist Family Physicians. Before we begin the session, I just want to remind you to keep your microphones muted unless you want to speak up. And at the end of the session, we'll share a Google form to gather your feedback to the WhatsApp group actually. So please take a moment to fill it out as we aim to meet your demands and requirements as much as possible. And so today we have two resource persons. Our first resource person for today is Professor Kumar Mendis. Actually, it would be very ungrateful of me if I do not introduce him properly. So let me tell a bit about him. He's a very prominent figure in the success of family medicine in Sri Lanka as a clinical discipline. After passing out from the university, he began his career as a full-time general practitioner, and later he joined the Department of Family Medicine at the Faculty of Medicine, University of Kelaniya. And Sir Halls, and he is the first person in Sri Lanka to attain a qualification in medical informatics, which he obtained from Netherlands. And after that, he joined the university, Western Sydney University, as an associate professor, and he still holds that position. Then he served as the Carter Chair Professor of Family Medicine at Kelaniya University, and currently he leads the Department of Primary Care and Family Medicine at Sabaragama University of Sri Lanka. And to date, he has the highest H index among the family physicians in Sri Lanka. I think I should mention that also. And other resource person is Dr. Marsh Muthathambi. He's a senior registrar in family medicine, and he is attached to the University, YMU University of Sri Lanka, Faculty of Medicine, YMU University of Sri Lanka as a senior lecturer. So now I would like to invite Sir and Dr. Marsh to begin the session. Thank you.
Thank you, Dr. Sindupa. Thank you. Yes, thank you for the introduction. Marsh, you can carry on.
Yeah. Yes. Good evening, everyone. And just I've added a different kind of a picture here in your right, in your left, because just to show that the multi-dimension of family medicine. And today you will get an opportunity to, and we will mainly focus about family medicine and family medicine principles. And you will understand how a multi-dimension approach is very essential for primary care doctors. So with this starting, I would like to introduce you to the app called GoSo Box. We will be doing some MCQs, especially the best response questions, and we will do it like a poll, and so that you can go ahead and give your answers, and finally we can see how you have fared as a group. So the instructions are given below. Just Google as GoSo Box in your mobile phone or your whatever the devices, and then you can click on it. And following that, it will take you to a web page saying that click. There will be several sign up and several options, 3 options. You have to choose the option of click joint event. You have to click the joint event option. And then it will give a space for you to type the access code. So here there is this 9-digit number. So if you type it there, you will go to the that GoSo Box web page, and you the first question will be displayed. So I have just given a small test question for you all to hold your votes, since we are awaiting this year presidential election. So I have given a question related to that, and we'll see how you fare.
Hello, Marsh, I can't see the question now. Alright, okay. බලන්න මොකද වෙලා තියෙන්නේ කියලා බලන්න. Because I am acting as a participant. Can you see now? Yes. Yeah. Yeah, okay. Hello. Hello. Yes.
Yes, hello.
Yes, sir.
Right. So I results of this poll මම ආපහුතර log on වෙන්නම්කෝ මේක එළියට ගිහිල්ලා. Can you see them answering the question now? හරි මම බලන්න කියන මගේ මොකක් හරි වෙලාද ඇති. Join event. Paste. Join now. මට එනං ඉන්න මොකක් හරි කමන්නේ ඒගොල්ලන්ට මේ they can see no. I wanted to right. මොකද්ද? ඔව් ඒක ඉවර වුණාම හරිනේ දැන් වෙලා ඇතිනේ. Right? Then show the screen.
So thank you, everyone. Sorry for a small technical glitch. So 28 have responded. So we'll see how you have responded it. Just check whether you can see the results now, everyone. Is it visible?
No, Marsh, we have to
Yes,
Marsh, it's not visible actually.
yeah,
it's
Results
visible.
are not results are not visible to me.
you have to get the screen Gozo box screen to
All right. Okay. So the okay. So
but some are saying that they can see. I'm not sure how.
We can see in our mobiles.
Okay. Right.
because it will automatically show the results to them, I guess.
That's the thing. Okay. If you enable the screen that you see, it will be there.
Yes, sir, sure. Give me a moment. So this is how so can you see the screen now?
Yes.
Right.
Yes.
Yeah.
Right.
So I
Fine.
think works. So we'll go on from there, sir. So I share the presentation. So thank you everyone for actively engaging. So this will help us to, keep ourselves engaged. Well, so we will be doing this session in under two main topics. One is like family medicine principles, and the next would be the mainly the management principles in the primary care level. So the first few questions are true false questions. So very sorry, we will not be able to use the go solve box for true false questions. We will give you 2 minutes for you to engage in this true false question, and then we can discuss the question with you. So is that all right, sir?
Yes, Marsh. But you all have to just get a
Time.
paper and a piece of paper and pen, and you answer your questions. Nobody is going to see what you have written. So when the answers are displayed, you can yourself see how you got some correct and some you did not get correct. So we want active participation, right? So say question 1, you say A true or false, like that. Within the 2 minutes, you mark the questions that you as you are doing a MCQ.
So 2 minutes over. Shall I go to the answers?
Yeah. Yes. Please, you carry on.
So would you like to discuss?
Marsh, you go ahead and discuss. I'll chip in if I want. You can go back and then discuss.
Yeah.
Yes.
So in this case, now we have to understand what does the comprehensive care, continuity of care, coordination of care, and opportunistic health promotion, more or less, the first contact care, all these words means. So now, so in this patient, 45-year-old housewife, already a regular patient who is coming for the clinic. So that shows you've been caring for that patient over a long period of time. So when it comes to continuity of care, you are treating, like there are few dimensions of that as well. You are going to continue the patient and patient health problems, and you are going to have some records of the patient as well. So all those things comes under continuity of care. And so now come for the treatment of her son, and which sounds more or less like a upper respiratory tract infection, right? And moreover, she's on her medications for hypertension, and you do the relevant things as well. So here the most correct answers would be the continuity of care, as I explained, and then the first contact care. Why? Because it's the first contact to the health system of this 7-year-old kid. So with the really undifferentiated symptoms, cough and fever. So that's why we have taken these two answers as the correct answers. So the so I think sir wants to
Please.
add, sir.
Yeah. All those who participate, mute your mics, otherwise, right? So, first contact care, as Marsh told you, in this episode, what we call this episode of illness, right? What the patient wanted was for her 7-year-old son with cough and fever, treatment given, right? So this is the main reason for encounter. Also, we can introduce another term, reason for encounter. Why people come to get medicine. That is reason for encounter, right? What the doctor does is, he examines the patient with cough and fever and give a prescription treatment for her son. So that is what we call process of care. Remember, I will just mention, not even relevant to this question, but these are the terms that you should understand, because this is a new discipline for most of you. So when we do gynecology and obstetrics, we have to understand maybe 20 or 25 words or 50 words of this specialty. In the similar way, family medicine, reason for encounter means why the patient comes to see you. Process of care means what the doctor does. And problem definition is our diagnosis, right? So apart from this, so what is the first contact care means why the patient came in this regard to get treatment for her 7-year-old son. That is the first contact care. Continuity of care, as Marsh showed, this lady has been visiting the clinic for a long period of time, right? And for her hypertension, right? And so the doctor checks the blood pressure, right? Okay. If you have any questions, you can ask, or maybe type into the box, right? But yeah, we can move on, Marks. Okay, we have got 2 minutes now.
Does anyone willing to give the answers for this second question?
False, false, true, true, true.
Okay, so we'll see how you have fared.
So can you repeat that again?
Yeah, this is false, false, true, 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 sir.
False, false, true, true, true.
So the answers in the red are false and the in green are marked as true. Yeah. So good.
Yeah, that is good. And have you the simple question I just want to clarify. Have you all seen and at least read the first 3 or 4 chapters of Prof. Nandini De Silva's lecture notes in family medicine?
To be
Now,
honest,
when we
no, sir.
Huh?
No, sir.
No, that is a must. Without reading this, you can't go on to other books, right? This is a very fundamental book that you should read, and you don't need to even buy. It is the PDF is available. I think Dr. Marsh will be able to give it. Marsh, you can Sindhu Power Marsh can put it on, because we have a PDF now, and Prof. Nandini has made it the license. She has waived out the license. Is the public domain now, right? So it is a must, because this is basic principles of family medicine, right? So the first one, I'm not sure people all understand this. As first contact doctors, we just can't say that we won't be able to deal with mental illnesses or gynecological problems, right? This is a fundamental principle. As first contact doctors, any disease, any age, any problem, chronic or acute, we have to deal. That does not mean that we have to treat. If we are able to treat, we treat. If we are able to not treat acute emergency, I mean, say myocardial infarction, we are not going to treat infarction, right? We make sure that the aspirin is given, right? And if we know a little bit more, maybe atorvastatin and the other drugs, pain medication, and then refer as quickly as possible to a nearest hospital. So this is the first contact care. We have to treat acute illnesses, chronic illnesses, mental illnesses, childhood, anything. You just can't say. So this is why what it means first contact care doctors. We can't say that certain things we can't treat. Comprehensive care, right, means family physicians will see all age groups, both males and no. That is not what comprehensive care means. And it is, there are 3 dimensions for comprehensive care, right? Again, I am referring to the lecture notes. These are very basics of family medicine again, right? Comprehensive care means you treat the physical, psychological, and social aspect. That is one aspect. I think most of you will understand that. Physical, psychological, and say diabetes. You treat the diabetes, a physical illness. Psychological illness, maybe he has to be careful of, patients will say, doctor, it is very difficult. I'm going to the office. I can't wait without eating, like that. And social thing. And then curative and preventive, right? So sometimes we can cure disease, sometimes we can prevent a disease, right? And the other dimension is the individual, family, and the community. So it is a little bit different. There are 3 dimensions to comprehensive care. If you have not heard that at all, it is very difficult. You have to read the lecture notes by Prof. Nandini, right? Coordination of care is easier than that. Coordination of care means we don't know everything. We have to get the appropriate help of a people have the wrong notion that we can only coordinate care with another physician. It is completely wrong. Say we want to do a eye checkup for diabetes, we refer to a ophthalmologist. That is, everybody will understand. We want to get an opinion of ischemic heart disease, we refer to a cardiologist, right? Everybody will agree. Not only that, we can refer to another family physician if we want. So in our area, there's a family physician who is good at counseling and psychological solving psychological problems. We can refer to that family physician. We can refer to a physiotherapist or a dietitian. Remember, so coordination of care does not mean only the physician. It may be a allied health care worker or another family physician, right? The first contact care family physicians deal with. Yes, as I told you, most of some of the, at least 20-30% of the illnesses we see are undifferentiated. Abdominal pain. First day, the patient will come just vague abdominal pain. Second day, maybe a little bit localized to the right side, but no. Third day, it's full-blown appendicitis, right? So on the first day, nobody can tell it is appendicitis, right? So we have to deal with undifferentiated illness and vague symptoms, right? That is the threat and the beauty of being a family physician, right? We have to deal with all kinds of diseases, right? So opportunistic health promotion is one. Yes. So somebody comes with, say a young person comes with, university students comes with cough and fever. For 4 days, we diagnose most probably a lower respiratory tract infection. We take this opportunity to give some opportunistic health promotion. Can anybody say what kind of opportunistic health promotion can we discuss with this young person? Anybody? He has come for a cold and cough. Everything is sorted out, written, and we take this opportunity to do some health promotion. Anybody?
Reproductive health, addiction, everything.
Sorry? You are correct.
Reproductive health.
What about reproductive health? You are correct. Yes. What about reproductive health?
The sexually transmitted infections and
Yeah, how can you are correct. You are correct. But what can we directly it is very important, as you say, right? If you are having, can we say you are not married, you are a university student still, don't have sex?
no, we can't.
No. If we tell even they will have sex, right? If not everybody. So we tell them to have safe sex, right? Use a condom if you are having sex with somebody, right? So that kind of thing, right? And about drug addiction, now it is rampant in universities, right? Even for a party, don't take stimulant drugs or don't experiment with hashish or this kind of, they will say harmless. Once, 1 or 2 times, it doesn't matter, right? Okay. Mash, right.
Yeah.
We'll go to the other one. You can do the next one. Right. 2 minutes now.
Okay, time's up. Anyone willing to give the answer?
True, false, true, true, false.
Okay,
True, false, true, true.
true, false. Okay, good. So would you continue with
No,
this?
you can continue, Vash.
Right. Okay. So yes, so I'm very glad that you all are doing it very well. So the rapport is the emotional element, very true, and it's very important as a family doctor. You maintain a very good doctor-patient relationship, and rapport is the main, I would say, the root element that you need. And then touching the patient is essential to convey empathy to a patient. It's false because we say like touching is appropriate touching if it's really necessary. Yes, and there are like certain places that where you can pat if the to show empathy and all. So you have to be very mindful. So touching is not always a sign of like to show empathy, but if it's required, yes. So that's why we have given it as false. So difficulty establishing eye contact may be due to depressive state of the patient is the correct answer. Because again, very important as a family physicians, you have to pick up the cues given by the patient. It could be verbal and it could be non-verbal. So sometimes very subtle because you are having a long-term relationship with the patient, and even subtle changes in this patient's behavior, you should be able to pick up. So that's why this is this correct. And signposting is used before the doctor asks personal questions such as substance abuse. And also it would, it's true, and it's also like account for like things like sexual history and something related to any sexual history or any other violence or so, any domestic violence or so on, because it's like you are giving a small warning shot, or like you are like signposting is a simple in simple terms if you are driving before a pedestrian crossing, you always see a sign in the road. So that okay, a pedestrian crossing is coming. So something like simple things like, okay, I'm going to ask you some personal questions, or is it okay if I ask you some personal questions? In asking in an empathetic way, should prepare the patient to answer your question. Then we all of a sudden, out of nowhere, we ask those. So this is very essential thing. And there's nothing called that you shouldn't talk during the physical examination. In fact, you can tell things like why you are doing it, and what are you going to see, and even you can use your time effectively, get some relevant history while you are examining as well, because as you go on, you would gather data. So with that, your hypothesis will keep on changing. So you can always talk if it's really appropriate during physical examination. So anything you would like to add, sir?
Yes, you made all the relevant. I just want to ask them, uh, you know, you can put your hand up and say that if we ask a question, do you know how to use that on this thing? Because otherwise it will be, we won't know. Some of you will be knowing, some may not know at all. Now, so the repo part, right? I mean, just when a patient comes, you may be entering the data or writing on the uh, medical record some of the details that you saw in the previous patient, right? And most of the time, you won't even look up. The patient will come, stand in front of you. You continue to write and finish this. Instead of that, you you don't even need to talk. Just made a gesture for the patient to sit, right? That is rapport. And acknowledge the patient's presence, right? That will go a long way to the patient to know that the doctor has noticed me. Doctor knows that I am here. But when you say this is followed by the repo, after you finish work, sorry, I had to enter the data, right? So repo is most of the time non-verbal gestures, eye contact. With that kind of thing, you can make the patient feel very comfortable. It is very important because that is the first time you meet the patient. When the patient enters the room, right? If at that point, if the patient feels that you are not interested, then you won't have a proper consultation. Patient will be discouraged, right? And the other thing is signposting is very, very important, as Dr. Marsh told you, very important to tell the patient that I am going to ask you. Just ask the permission and warn. Especially as Marsh told, if you're asking about sexual matters and even say substance abuse, as you say, alcohol problem, problem of taking narcotics or illicit substances, right? Anything that may surprise the patient or put the patient in a little bit of uncomfortable situation, you give a warning, right? I am going to ask you some personal question regarding, you can mention about alcohol consumption, or say, I just want to talk to you about some domestic matters. Maybe it is between yourself and your wife, but I had to ask this from you because of the history that you told me, right? Okay, Marsh, any questions that you want? And I have just written also, you can type in the questions to the chat box if you don't want to ask, because some people will be shy. You can just type into the chat so that we will see them and try to answer. Okay, we'll go on to the next one.
Yeah, this is SBA type question. So I have activated the GoSo box. So you can give your answer, log in and give your answer there itself. I'll give you 1.5 minutes since we are moving slow. For the latecomers, I will give the instructions. Go to Google, type GoSo box. You can see the instructions here. And then you can click on it and just select joint event. And it will ask access code, and this is your access code. This 9-digit number. So those who are unable to see it via GoSo box, I have kept it here as well.
Remember that we will not be able to see your identity, who gives the answer. Even if we want it, we can't. So don't feel that GoSo box will get your identity. We can't see anybody's identity.
Okay. So I'll give you another 30 seconds because maybe you are not familiarized with GoSo box. If there's any concerns, please let us know. So 2 minutes have gone.
Yeah.
Shall,
Yeah, you
uh,
can
yeah,
display the how many have
yeah,
asked the mass. All right.
yes, sir. So 17 have responded,
Right.
and majority have got the correct answer.
Okay. So discuss a little bit about this and then quickly we'll move on to the other one. So
Yes.
what happened to the others? I mean, there are about 52. Only 17. Yes. Right. You will discuss and move on to the other because.
So here, Mrs. Javardhana, 68-year-old woman, presents with a letter from a cardiologist for the referral you have given. So in addition, Mrs. Javardhan requests you to look at her ankle, which she probably sprained trying to climb upstairs. So here we have asked what are the principles the family physician have used. So you can simply understand that we were so nicely explained about the coordination of care, not only among the medical practitioners, but also with others. So here we have demonstrated along with a medical practitioner, and then she has come for this is the first uh, reason for encounter for a new problem. So again, so you are providing first contact care, right? So that's the answer. And we'll go to the next question. So meantime, I will enable the next MCQ as well. Yeah, you can answer it in the GoSo box as well.
Yeah, just a minute, Marsh. Now,
Yes.
you may be wondering why we are going mainly on the principles and functions and roles and scientific foundations, because most think that family medicine is cut down or enhanced version of internal medicine. It is not, right? And don't think that we will make sure that we get at least 25% of the questions on family medicine principles and roles. It is not only medicine surgery that you will have to know. You have to know medicine surgery and the clinical stuff, but these are absolutely important. Remember, this is why we are giving you these things, and we think that this is basic stuff, right? To move on to higher stuff, you have to read at least a book called book on lecture notes. And if you want to read more, McQueenie is the principal, but don't try to do a lot. But at least read the first 3 or 4 chapters of Professor Nandani's book, right? We'll get on to the principles. Okay.
So I will give you 1 more minute for you to complete that.
Hello, Mash, what happened? There's a logo coming up. Hello.
Dr. Marsh?
I think Dr. Marsh has dropped out for some reason.
Okay, I'll call him and see.
Yeah. Oh,
Yeah, apologies for the technical fault. So, sir, I'll go for the answers.
right. Okay.
Right. So here in this question, again, we have given it as whole patient care. Maybe you might have confused with the terminology, but ideally, we usually use the comprehensive care. So again, in this case, you can see how a patient coming with headache, but the root cause or the trigger as a psychological problem is being identified, and how the family physician is catering for that problem as well. So this is an example for how the comprehensive approach, as said, the biological problem and also the psychological issues are being treated in the context of the community or in the family. So this three-dimensional approach is quite important. So, sir, anything that you wish to add, sir?
Can you get back to the question? I just.
Yeah. Yes.
Okay.
So we will move on with the other management related principles in the primary care. So it's a true false question. No need to go into the go soap box. Just go. I will give you 2 minutes for this. Right. Thank you. Anyone wishes to give your answer? So we're pretty easy question.
False, true, 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 true.
Okay. So we'll see how you have fared. Okay, so I agree with the first one. Yes, it's false. I mean, like everyone, we would advise on lifestyle management. Obviously, if the BMI is more than 23.5, that's a Asian cutoff for overweight. So there's a role, definitely there's a role of lifestyle modifications. So the empty calories means the calories comes from the foods that have no nutritious value. For the examples would be the soft drinks or alcohol or things like that, where there is hardly any nutritious value, but it contains a lot of calories. And the third one, recommended exercise time for adult is at least 150 minutes of moderate aerobic activity for a week. That's true. Usually they say like the WHO recommends 30 minutes of aerobic activity 5 days. And also it advocates for at least 2 days of resistance training as well. And with the current WHO guidelines, there is no safe level of alcohol for adults, or I mean like for anyone. So WHO no longer recommends this. Previously, there was this the consensus, some element of I mean like the different levels, 14 units for females and 21 units per male is acceptable, but no longer WHO recommends that. Smoking within 30 minutes of waking is an indication of nicotine dependence. That is true as well. So anything, sir, wish to add, sir?
Okay. I will start with alcohol, Marks.
Yes.
Right. At least if somebody wants to take a drink, right? So there's a recommendation 2 units. The other thing is, I hope you all understand what a unit is, right? One standard unit of alcohol. How do we measure? Is it a glass of beer, half a glass of arrack, gull stuff, or coconut arrack, or old arrack, wine, how much? That these are very, very important things you will have to understand, right? 30 ml of 40% of 40% alcohol, that means standard arrack, whiskey, that kind of thing, 30 ml is one standard drink, right? So understand that, because otherwise standard drink means some for people whole glass, one glass, right? That also they will say, doctor, මං හිතුවා ඒ බීදුරන් එකක් කියන්නේ එකයි කියලා. No, 30 ml, that is out. You have to stress very carefully, right? And if somebody wants a drinking level, still there is now this is a very good differentiation of males and females. Males are allowed 2, females 1, right? 5 days of the week, at least 2 days free of alcohol. That means maximum of 10 standard drinks. You can't say that I have not taken alcohol. These are the one. Binge drinking. People say, doctor, I don't take alcohol at all from Monday to Friday. Friday, doctor, පොඩ්ඩක් ඉතින් වැඩියෙන් ගහනවා. Nothing like that. You can't accumulate and drink on one day. That is one thing. Very important to stress for people, right? So the other thing is lifestyle modification. My take on this is, right, lifestyle modification per se will do very little. You have to give some encouragement. You always stress on lifestyle modification, especially in the BMI category 30 and over. You start with some kind of medication plus lifestyle modification, right? Because otherwise they get discouraged. There are very few old people only that will adhere strictly onto the lifestyle modification, right? So this is my personal take on this. It is still very important, but combined with another medication, there are harmless medication as side effects are almost minimal. There are also drugs that with side effects, right? You can use a very simple Senecal or something like that, right? Right. So, and lots of large number of empty calories. Yeah, chocolate cake, rolls, every lot of things are empty calories, right? These are the things that accumulate weight in us. Okay,
Yes, sir.
Vash, I think we'll
Go to the next one, sir. So
yeah,
have
and we will go on to maybe a medicine one. They may be thinking that we will be not taking. Shall we skip
shall we
this
skip?
and
Yes,
go
sir,
on?
sure.
Yeah.
Okay, sir.
Yeah.
So
Right.
I'll so on the go soap box as well, sir.
Okay.
This.
Okay. 2 minutes is more than enough.
You can answer in the go soap box as well. I have enabled the question. Single based answer type question. You have to choose one answer from that. I would encourage you to answer so that we can go for a discussion and we can see how it goes. Yeah, we will have another 30 seconds. Only 12 have responded still. So I will share the answer.
Yeah.
Okay.
19
So the
only.
yeah. So in this question, the expected answer was refer the patient to the urologist. 32% have got this answer correct. So we'll go back to the question. Oops. Yeah.
Yes. Yeah. So as a family physician, this is one thing that we test what you are able to do and what you are supposed to direct to another specialist. This is one area that you should not play with patients. If there's a nodular prostate, there's no questions. You can maybe you have several options, but the main thing is to get it sorted. You have to refer to a urologist or a surgeon to get it sorted, not use drugs. So this is one type of question that we test you whether you are a responsible family physician who will refer appropriately, right? So nobody will say if a patient comes with sweating and slight left arm pain with breathlessness, you will treat and see. No, you will say, I will direct to the nearest hospital as soon as possible, giving a aspirin and the other things. So similarly, right, this is one thing that this type of questions we set to see whether you do the appropriate, because it is very risky exceeding your limit, right? Okay, we'll move on to the
Sure, sir. And to adding to that, sir, I wish to tell the candidates, because identifying red flags is very essential at primary care. So you will be definitely tested on those. So when you study also, maybe the tendency would be for you to study about the drugs and the newer things. Likewise, usually the treatment plan, but also as a family physician, you should always keep in mind that you should not miss things.
Yes, I agree.
Okay.
Red flags are, you don't go to meddle about with this. Right? So very important. Sometimes you may, I mean, even in OSCE, right? So sometimes you fail. And so if you are on the fence-like thing, we will go through the thing and see whether you have missed some of these, red flags and must-pass questions even, right? Okay.
Okay. So I have enabled the next question in the Go Soap box. So Sabatin has responded so far, sir.
Okay.
I will give the answer. So this is how the majority have opted the answer B, the glycoside MR. Actually, the expected answer for this question was, so you can see, so in this question, this is a 55-year-old diabetic patient with a BMI of 32, which is class 2 obesity, and coming with a deranged sugar reports. He is already on metformin 1 gram BD, which is the maximum dose, and his atherosclerotic cardiovascular risk is less than 10%. So if you dig deep into the guidelines, national guidelines, or as the which is recently in 2022 put up by the College of Endocrinologists. I would highly urge you to read that guideline. You can see metformin and lifestyle modifications is the first line. And then if there's any established atherosclerotic cardiovascular disease, or if it's high risk, you would anyway straight away start with SGLT2 inhibitors, which is empagliflozin, dapagliflozin, canagliflozin, likewise. So if not, right, and then you would see if you are not getting the target. So here, despite HbA1c level, if there is any atherosclerotic cardio, if it's a patient's high risk for atherosclerotic cardiovascular disk, despite HbA1c level, you have to start, if the patient can afford, you have to start SGLT2 inhibitors. So if not, if the patient is HbA1c is not optimal, or the glucose its control is not optimal, and since the patient is obese, and to aid weight loss, the options would be again the SGLT2 inhibitors and GLP receptor agonist. So these are also coming to market, like semaglutide and things like that. But again, here with the given answers, the option is empagliflozin 10 milligram would be the appropriate drug for this patient. So here you would see, like, from the spectrum, we started with family medicine principles, and then not missing things, and even you have to know about the basic drug management of the common conditions in depth as well. So anything, sir, wish to add, sir?
Yes, I was surprised that only 3 gave this, right? And because you have to know about this class of drugs, SGLT2 inhibitors, because these are, to me, I mean, these are some kind of magic drugs. That this is the wonder drug, if you ask me, because it has so many good effects. I am not sure any class of other drugs recent out of this has this amount of drugs. Say against yeah, these are thing. At least I am not sure, Mars, but if I had the option, I don't know. We'll ask. I don't know whether Sindhupa and others are there.
Yes.
My if we have a diabetic, if I get diabetes, which I will soon get, right? With metformin, I will take empagliflozin.
Yeah.
For sure,
Yeah.
right? Because metformin will lower the blood sugar, but it has not got protective effects on the heart, kidneys, and the other thing.
Yes.
Right? And one thing is the price, Marsh. I mean, how much is the tablet now? 75, 50, or
Yeah,
what?
10 milligram tablets is it's in market. Certain brands are there for 50 rupees.
50 rupees, yes.
And
There's a Sri Lankan brand, no?
yes, sir.
Impa, yes. Yeah.
And
So
25 is 100, around 100 rupees.
yeah. So all the others increase weight gain, glycoside, insulin, right? So you can't, at least from that angle, you can't give this because BMI is 32 again.
Yes.
And he's on the maximum metformin. That is one thing. Because the other thing is, if you know, people can't tolerate the maximum dose of metformin. Say 1 BD mostly will tolerate. Then my thing is, I think still, if you go and see how many opted for sitagliptin, it is completely out. There's no place for sitagliptin now, I think. Can you just go back and see how much?
Yes. No, it's actually, if it's metformin is not tolerated, I mean, like, it's coming down. The DPP4 inhibitors.
Yeah. And what did the trainees think of that? did they, I mean, what is that? Go soapbox. What did they tell? I think more
Yes.
prescribed
Glycosides, majority prescribed.
majority. Yeah.
And yeah, few have opted for
Yeah, sitagliptin and empagliflozin are almost 3-3, no? Yeah. Glycoside, you just can't, because it will what? First thing, what will glycoside do? It will increase appetite, if I'm correct. Is it?
yes, sir. And weight gain, then they are
Weight gain also, right? So you are already having a, I mean, it is true that it will lower the blood sugar, but it will again increase your appetite and also, right? So, and nothing of this is the other thing, nothing similar to empagliflozin. Any of these drugs has a positive effect on the heart and the kidneys. That is the main thing, right? So I don't know how much long will they take, but with metformin, the second choice, I think, if people can
more
afford, I
serious,
think will be Empa. Right.
weight more seriously. But now the even the guideline says if the BMI is above 30 in a diabetic
Yeah.
patient, it's possible to go for a metabolic surgery.
Yeah.
So the question number 10. Yes. So again, go to GoSo box. I would enable the question. Yeah. So you can answer in GoSo box. You have 30 minutes more, if possible, give an answer. We can identify whatever the answer that you have, whom you are, and I mean like from the answer. It's de-identified platform. We can get an idea whether you have asked the ideas, and we can get idea to how which extent we have to discuss. That's why the whole idea of this. Good. So only 8 have responded, sir. Are we to wait?
Yeah. We'll move ahead. Yeah, we can't wait
Okay,
because we
okay.
have.
So the answers are as follows, sir. Majority, around 35% have opted changing actually. Dermatomyositis and rabies.
Yeah.
I'll go to the question. So I think it would be nice if you
Yeah, if now why I included this is sometimes we have to know rare diseases that we see, right? It's rabies is one such disease, right? So how to go about if we are not sure, right? So how I try to explain this is polymyositis and dermatomyositis. Both I know a little bit only. Say these are proximal muscle diseases, right? Proximal muscles are affected. So nothing of this sort is given in the history, right? And Guillain-Barré, you know, is a ascending paralysis, right? So there's nothing of that sort. So it is poliomyelitis and rabies. And also now this is a homeless person, sleeps outside, more prone to a dog bite, right? And only one leg gives the symptoms. And if you have read even a little bit of rabies, the pruritus and the pain and temperature, confusion all lead to rabies, as we know. I have seen only one when I was in Australia about the in these dermatomyositis and polymyositis. It is very rare. I'm not sure, Marsh, whether these are common here. I have not seen unless you work in the maybe rheumatology section. Guillain-Barré, you have
No,
heard. Yeah.
not usually for the primary care, sir. The
Yeah,
usually the
that's the thing. It is a thing that you will see in a specialized setting, right? So, but you have to know, even I'm not sure whether we have had positive rabies in this last 3 years in Sri Lanka, Marsh? Anybody?
So, so I will search for it. So and
Yeah.
before this, I will.
Yeah, I don't think we have had because we have controlled rabies and suddenly from the wild animals we can get so new message. Yes, 2 cases. Yes, can you just tell a little bit about Shashi Abhisekara? Yes.
Yes, sir. The patient
Yes.
was a 10-year-old boy, the recent
Yeah.
one,
Yeah.
transferred from Kuliyapiti hospital,
Yes.
suspecting uh, autoimmune mediated encephalitis.
Yes.
But during the LRH stay, we confirm it as rabies,
Yes.
and all the characteristic features like fan sign and everything was there,
Yes.
and child died in 3 days.
Right. And what was the how did the child contact rabies? Wild animal or just a
No, it was a stray
stray
dog,
dog?
and the child's mother was also a psychiatric patient,
Yeah.
and the father was bedridden after an accidental fall, spinal injury,
Yeah.
and that sort of social background.
Yeah.
And they haven't gone for a proper medical care after the bite. So
That's
at least there is a negligent part also. Sir.
that's the thing. So still rabies is with us, right? So please, I'm really happy that I was wondering whether I should put this question or not, but at least we have evidence that at least somebody has seen, and you know this is. So out of this, what is the thing that you saw, Dr. Abhay? What was the child presented with? Not the normal, you know, fan sign. Before that, how did the, because it is important to share your.
Yeah, sir, it was actually when the child come to us, it
Yes,
was a kind of a late presentation
representation.
because
Yes.
because the child was managed in Kuliyapitiya. Now it's a teaching hospital.
Yeah.
So
What did the
further,
child presents with at Kuliyapitiya? What did the child present with at the to the Kuliyapitiya hospital? Do you know? Or it was not very.
yeah, it was like history was like fever
Yes.
and confusion, altered behavior.
All right.
And that is why they have suspected encephalitis.
Encephalitis.
But when a child comes here, more signs and symptoms develop, and it was easy for us to diagnose it as rabies.
Yes.
But I think the early presentation at the Kuliyapitiya, they are having the doubt.
Down. And
Yes.
did the child give a history of a animal bite or dog bite?
Yeah, they have given the history also.
That's the thing. That's the thing. I mean, so can you see, at least ask about, encephalitis, at least just passing question, because it is very important. I also was thinking that we have controlled rabies. 2 cases you said, no?
2 cases, sir. The last one is very much thorough because the previous case was there, I was not there.
Right. Okay.
I was recent.
Right. Thank you very much for sharing the information. Right. Marsh will run on to the next one.
Yeah. Epidemiology unit says for the
Yeah.
over the past decade,
Yeah.
the numbers are like 25 to 30 cases.
25
Deaths
to
are being
30.
reported.
Oh,
30
then
deaths are being reported.
so still
there,
with
it's
all
out.
these, vaccination and right, because stray dogs, I think.
Yeah.
Stray dogs, that's the thing. Okay, thank you very much. So rabies are still with us, remember.
Okay, I will enable the next question.
I hope all of you get this correct. Please answer it within 2 minutes.
So shall I share the
Yes,
answers, how they...
Yes, please. I hope that they got it correct. Oh. So still even 19 said loosen the and gave it 2 breaths. 3 percent inches. Right, okay. We'll get on to the question.
Okay, sir. So here you see a unresponsive patient.
Yeah. Can we get on to the question, Marsh? The question?
My
They can.
apologies. It's been not shared. Yes, sir. Right. Over to you, sir.
No. You can go on, but we still right. This is the thing.
Can you see, sir?
Yeah. Now can.
Yeah. So there's unresponsive patient, and it's basically and in the answer also it's been given like you assume there had been a cardiac arrest, and so what we have to do, it's like basic life support. As correctly said, we would expect everyone to be thorough on this, because in foreign countries or in abroad, even the lay people are being trained to do these things. So the answer would be like immediate resuscitation. You start with chest compressions at a rate of 100 per minute. So that is you check for the patients to see if we have any there's no any signs of any I mean, like if the patient is unresponsive, immediately chest compressions has to be started. That is what been expected in this question. And all the other things have been like secondary, and few things which would come along the way. Anything to be added, sir, from your point of view?
Main thing now, the old thing, old traditional things of mouth to mouth is not important at all now. First, you get the circulation going. First thing is you don't you don't jump the gun, right? So because in the stem, you say you observe, then make sure he does not respond. First thing, right? Shaking and shouting, that is the first thing. And then you request a nearby person to call the emergency hospital. We have a very nice emergency service now in this country. You do these two things, and then only you start what you have. Previously, there's a long history of, the thumping. You don't need to give two thumbs before you start the chest compressions, right? And you give it a fair amount of, at least 2 inches, right? You can break a rib, it does not matter. But what we want is the patient to survive with 2 broken ribs or 3 broken ribs, right? And no mouth to mouth. If you really want 30 compressions and 2 2 breaths, right? And people will not, mostly will not like to give mouth to mouth to unknown person. No problem at all. But you can't stop the chest compressions until the ambulance arrives. That is the main thing, right? That is the main thing. You don't stop chest compressions, even if you don't want to give 2 breaths after 30 compressions. If you want, you can, but it does not matter. Just comply with the chest compression, go on until the ambulance arrives. It is a strenuous thing, remember. It is not easy. If another person is there, you quickly change with them because it will take, especially in a rural setting, it will take some time for the ambulance to come, right? Okay. So remember, please, there's very little frills, and previously we were asked to do certain. Now it is very simple, right? Check, then ask somebody to call, then start your chest compressions. Okay.
So again, you can go to the soap box and give your answers. I'll give you 2 minutes. So shall I share the answer?
Yeah, yes.
So this is how they've been faring, sir. Majority have opted for the correct answer.
Okay, that's good.
So going back,
Yeah,
the
still 6
questions.
have got it wrong.
Yes. So it's like few things that you have to keep in mind. Now, initially, there are different levels of prevention strategies. Now, there have been now we call primordial prevention, primary, secondary, tertiary, and now we talk about quaternary prevention as well. But at least at the basic level, you need to know about primary, secondary, and tertiary levels. So these are very in a nutshell, you can see like taking away the risk factors or acting before the onset of the disease is what is meant by primary prevention. So after the disease has been established, we identify with screening and catching them quite early and diagnosing them and ensuring they don't get into any complications. So basically the screening part. So most of the other answers would be like with go in hand with secondary prevention strategy. And then in the tertiary prevention, we try to reduce the complication of the diseases. So by optimal control and treatment. So if you see, the answer would be like promoting immunization against HPV virus so that we eliminate the risk factor for cervical cancer. That's been expected answer. Shall I move forward? Sir?
Yeah, yes.
Again, I on the Go soapbox. So may I share the
Yes.
answers, sir?
Yeah.
So this is how you've been fared. So many have opted for the option of unexplained lymphocytosis. So I do understand this question is a bit of a ambiguous question. You might find it like bit go in depths of theory sometimes. Because now here in this patient, you should suspect lung cancer until proven otherwise. Because with this, so I mean, like he's a high, I would say like we have not given much of symptoms, but then we would ask like this patient is a high risk for lung carcinoma. So the commonest features of lung carcinoma would be paraneoplastic symptoms like hyponatremia due to inappropriate ADH secretion, or if not hypercalcemia. And even you can have anemia, like mostly it would be like microcytic anemias are common. Another feature which is been noted with um, non-small cell carcinomas of the lungs is thrombocytosis. So this kind of like even in a screening exam, sometimes the rare few things they might need to ask, like at a primary care level, you might be vigilant about what are the possible uh, test investigation which would lead you towards a diagnosis of a cancer. So as I previously said, identifying red flags and their symptoms and signs, as well as the investigation findings are some things that been tested in the exams as well. So would you like to
No, Masha,
anything?
I also want to ask a question now. No, previous one.
This
Now,
this one, sir?
yeah, this one, unexplained high MCV. Is that also a feature of smokers?
Mainly, sir, that would point towards a nutritional deficiency. If
Right.
they are malnourished, and if there's a uh, coexisting nutritional deficiency or any alcohol
Right.
use,
That's the thing. Yeah.
it can
Yeah.
can
Yeah.
be.
But thrombocytosis, I mean, that's a very important thing. I mean, we are just vigilant about this, right? We can, I mean, a simple test. I mean, you get the report in any kind of full blood count, no?
And so, like mostly at our context, we are more worried about thrombocytopenia because of the dengue,
Dengue, yes.
and we hardly associate
Yes.
thrombocytosis.
So it should strike, because we are looking for a downward trend. And if we say, if we even don't know the patient, we can always ask, are you a smoker? Okay, Marsh, right. Get on to the another one.
So I will enable the go soap box as well. Again. So shall I go ahead with the
Yeah,
answers?
yes.
So the majority have opted the option of observation and follow-up.
No, yes.
So as you see, we are going in more and more into the theory related stuff. But again, this is a very common thing that you would find in the primary care level, where the patients are very reluctant to go to hospital and they would come and ask your opinion on what you would do and what they should be doing. So this is another skill that a primary care doctor has to possess, that to know even at least the initial few steps of management of something that would think the critical things. So here, if you see this patient's a young chap, there is so this patient has had a uh, pneumothorax previously as well. So again, now coming with some symptoms and signs of pneumothorax, and we have done a X-ray, and it shows 1.5 centimeter rim of air. The other important thing is there is no other pulmonary pathology is given. So when it comes to pneumothorax, we have to differentiate whether it's primary pneumothorax or secondary pneumothorax, because the management totally entirely differs from primary and secondary. So in this chap, 22-year-old, previously healthy, and it sounds like a spontaneous pneumothorax, which is primary pneumothorax. The X-ray also point to us there is no other pathologies going on in the lungs. So in this case, uh, according to the guidelines, less than 2 centimeters of rim of air, or less than 2 centimeter of the diameter of the pneumothorax can be safely observed and followed up in the primary care. So again, even this patient, if the patient goes to hospital or get admitted in the hospital, they would again send this patient with referring to the primary care physician. So in an ideal kind of a setting. So again, the knowledge has been checked whether you are aware of these conditions and whether you can give correct advice for the patient appropriately.
Marsh, just another question. How would you advise a primary care physician to follow this patient up? What are the things that you would say safety net? If this symptoms occur, come and tell me. And would you go for another chest X-ray, and when? Can you answer?
Yes. So, first thing, as we very correctly said, safety netting is the essential thing that we have to tell the patient. If the patient is become dyspneic, the patient feels like shortness of breath at any instance, immediately rush to hospital.
Right.
So that is one thing. That is to see if there is increasing in this thing. And sir, if I'm not mistaken, in 2 weeks' time we have to do another X-ray.
Yeah.
To see, and usually within a month or so it would resolve automatically. So 2 weeks or so, I'll just double check and I will inform the next whoever doing the next session, or I have another session. So at that time I will inform them.
Okay.
As so that is about.
Okay.
So final
Yeah.
question. It's a true false type of question, just to enrich you regarding the current management guideline of diabetes. So we'll quickly do this and then we can wrap up the class. The true or false type of questions. Right? Would anyone would like to give the answer for this question? Anyone would like to attempt?
True, true, true. False, true.
Okay. So, well done. So these are straight away taken from the guidelines, and these are the recommendations. Any adult above 35 years of age, Sri Lankans or South Asians has to be screened, and anyone below the age of 35, and if they have any of these risk factors, has to be screened for diabetes as well. So apart from that, adolescents above the BMI of 85th centile, and also females who are expecting a pregnancy also has to be uh, screened. Sir, I wish to just say a few things about the our previous questions regarding the pneumothorax.
Yes.
If it is 2 centimeters, what the NICE guidelines suggest is observation for 4 to 6 hours and then discharge.
Yes.
And they say they can safely discharge if the oxygen saturation is 96, above 96, and if the heart rate is below 100, and the respiratory rate is below 20. So there's
So
no
all these
dyspnea, no
things
tachycardia.
should be less than 2 centimeters plus the other things, no?
Yes, sir. Less than 2 centimeters. They usually would observe for 4 to 6 hours.
Yeah.
And at the end of this observation time, they would check for these parameters. SpO2 more than 96,
Right.
pulse rate less than 100, and then they would discharge, and they would again the follow-up would be arranged with the general practitioner with within the first week, sir.
Okay.
And follow-up X-ray has to be taken after 2 to 6 weeks of, or so 2 to 4 weeks after the hospital encounter.
Okay. And the safety netting is if any increase in the symptom,
Pain,
straight away
yes,
to
sir,
hospital.
straight away to hospitals.
And Marsh, one thing, the last thing, I mean, you put up this slide, we always forget, right? So this is my experience. No, get back to the other thing. Yes. Now, in this risk factor, we almost all agree on this and check hyperlipidemia. We forget the antipsychotics. There are a lot of psychological disease patients on antipsychotics, and they are noted to increase the blood sugar, and we don't even care for this. So remember, anybody taking antipsychotics for a long time, you bet your last 5,000 rupees because 1 rupee or 100 rupees won't matter any longer, right? So antipsychotics, note, this is my experience in Australia. There are a lot of people, young people, are diabetes, they don't know. It's not to their fault. They can't stop the antipsychotics, right? So please have a check on this because this is a neglected group of patients, right? So even glucocorticoids, I mean, asthma and other things, we note this and we will check, but not the antipsychotics. Thank you much for having this slide on. Okay, then we'll wrap up, I think.
Sir, isn't the current BMI is cutoff value is 23.5, sir?
Sorry,
Yeah, I think the doctor asked regarding the BMI cutoff.
right. Okay.
For the so the Asian value would be 23.5.
Yeah.
And up to 27 point, I forgot, sir. So up to
Yeah.
27, I think it's
It is
overweight
not the European
and about,
values, remember.
and 27 to 30, it's class 1 obesity. And then from 30 onwards, 35, class 2 obesity.
Because South Asians have a tendency to high risk of diabetes. Is it Marsh? Yeah, South
Yes,
Asians.
and South Asians, yes, and also higher percentage of adiposity in the body's percentage, in terms of a percentage.
Okay. Any other questions? Parting? Any others want to ask questions?
I think so. There is one question in the chat box. Any adult screen for diabetes less than 35 with any risk factors? What is the low margin of age? In the guideline, they haven't given about the lower margin of age, but I do understand when it comes to family history, how do we define as from which end we are going to?
Yes.
Yeah. So I have asked, is it 20 years?
So what would be
That's
an adult less than 35?
Because the guideline just says below 35. It
Yeah.
doesn't specify from, but I think the Australian guidelines, of course, goes from 20, I guess.
Yeah. Maybe if the both parents are diabetes. Yes.
So we'll double check, cross check
Yeah,
on that, and I will get.
Okay, then.
Could you please
Thank you,
show
Doctor.
question number 5 again, sir?
Sorry, question number?
Yeah,
Sir,
question
could you
number
please
5.
show
Sir.
question number 5, sir?
Yes.
Question number 5 or 15?
5, sir.
All right.
Sir, can I know the answer for this? Is it whole personal care, sir?
Yeah, actually, this should have been like, I mean, like, what was meant was the comprehensive care
Comprehend.
is what, yeah, what is being given
With
holistic care or
3 months duration following a diagnosis, tension headache was made. On further questioning, where the subject is married to couple and the doctor asked for a family meeting with his wife. The respect of displayed in the above, continuity of care, displayed in the above, what is the aspect of family medicine? Yeah, if it is a worded sorry, comprehensive care, Marsh, it would be better, no?
easily understood, sir. Yes, I think so.
Yeah. Is it clear now?
Yes, sir.
Sir, what is safety netting?
Safety netting. Marsh, would you like to answer that? Yes, very, very important thing. Again, another phrase we use in primary care often. Safety netting. Yes.
So in late terms, I would say like safety netting is something when we walk under, I mean, like on roads, we see there are these tall buildings, and usually they put a surrounding kind of a net to ensure nothing falls from up to downwards, and also even the safety of their workers and everything and so on. So even whoever passing by are safe, and also the workers are also somewhat protected. So I take it in that literal way. So basically the safety netting is, if a patient comes to us, we see like in primary care, we tackle mostly the undifferentiated problems. And so very correctly said, as example, we might get abdominal pain on day one, patient coming with abdominal pain, vague abdominal pain on day one, and nobody can diagnose or exclude the appendicitis on day one. But maybe in 2-3 days time, that might turn out to be appendicitis. So we as primary care physicians, we mainly treat thinking about the probability and alleviating the risk or harm for the patient. So when we treat, the common things are common. So in case of abdominal pain, we might treat the patient as acute gastroenteritis or possibly a gastritis. But again, we would tell the patient some instructions, give the patient some instructions. If the pain is not getting worse, or if the pain is shifting towards your left, right side of lower tummy, or if you are having any vomiting, or in other terms, we would give the symptoms of more of a sinister thing. And we would say, if anything like this goes on, you have to come back to us. So similarly, in the case of pneumothorax, we tell the patient that if these symptoms are coming or anything getting worse, you have to go and get admit yourself in the hospital. So that is, we are treating the patient holistically, and we are also empowering the patient, where he has to be empower the patient on his safety as well. So even like for a patient who coming with the day one fever, we would say, okay, if the fever goes on for 3 days, come and see us with a blood count, because the dengue is there in the vicinity. So all those things falls under safety netting. So
that is very important, Mahesh, the three examples, right? Because again, remember, as primary care physicians, first contact care physicians, family physicians, we see diseases in the early stages. Everybody will be, I mean, this is the, sorry for, I am not accusing anybody, but when the patient comes on day one and day two, maybe to a family physician, first contact care physician, and day 5, he goes to the hospital, the hospital doctor will ask, කොහෙද මෙච්චර කල් හිටියේ? කවුද බැලුවේ මෙච්චර කල්? I mean, at day 5, anybody can say it is appendicitis or similar thing. But day 1 and 2, nobody can say. And you cannot expect the family physician to order a ultrasound scan for abdominal pains of 1 day or 2 day duration. So these are the probabilities, as Master, probabilities that we deal with. What is the most probable thing at this point in time? And the probabilities change, right? So it is a very important thing. If we cannot accept the treatment now, if somebody likes very, very definite treatment and the diseases, he can't, especially if somebody likes to be very clear about the diseases he or she treats, it is not good for that person to become a family physician. We have to deal with undifferentiated illness. That is part and parcel of the specialty. And if you can't, you have to be, right? Sometimes during the dengue epidemic, we see patients twice a day, right? Because the probability of sometimes the blood count is 180,000 within a matter of 2 or 3 hours, it can drop below. And we can't send everybody, the blood count drops from 200,000 to 180, 160, everybody to hospital. We can't do that, right? So can you see how the family physician deals, right? There's a lot of probabilities that we deal with, unclear things. Everything is clear as the time goes on. As again, what we say is, you may have heard time as a diagnostic tool. We use time mainly as family physicians in diagnostic diseases. It is the only way possible, right? And we deal with using very simple tests because we can't order a lot of tests for each and every person, right? So very good question. I hope that you have got this safety netting, red flags, right? Time as a diagnostic tool, all these things very clearly. These are 4 things that we do in family medicine.
Thank you, sir.
Any other questions? We will.
Okay, will it be considered true? I think the question on yes, this question. Ultrasound scan, and I think so. In this case, if there's a higher suspicion of malignancy, anyway, respective of investigation, waiting for investigations, I think so also previously said it's prudent to refer to the appropriate in this case for a urologist for further treatment and I mean like further assessment and urgent treatment.
Urgent treatment, yeah, that's the thing. Because you must know the normal consistency of a prostate gland. If it is not normal, if there are any kind of nodular things, you have to refer. I mean, this is what we call, we have to know our limits. This is the other thing, right? If we refer a little bit prematurely, it doesn't matter. If we refer lately, then you may be dealing with dire consequences. This is the thing. So if you don't know, ask somebody. If you are not sure, refer. That is my principle. You just can't be taking chances with another person's life, right? Hope that is clear, that this is the principle. If you are not, I mean, this is not a normal prostate. So I don't have to, deal with this. I don't have to say it is enlarged. I'm sure everybody has. So the other thing is doing a digital rectal examination. I think this is a must for everybody, right? Get used to the feel of doing a per rectal examination and feeling the prostate, right? Okay.
If there are in absence of questions, we can wind up the
Wind up the
sessions.
thing. Yes.
Yes, so I think that brings to the end of the today's session. Dear participants, we have shared 2 Google form links to the WhatsApp group. Please fill those out. One is to get a review, I mean the feedback about today's session, and another one is about all the things we have done so far. So please be kind enough to fill those 2 questionnaires in the sense those 2 Google forms. So our next session would be on the next weekend, and we'll be informing you about that. So thank you, and dear sir and Dr. Marsh, thank you very much. Thank you very much for all the theories and all the questions you did. I think this session was really important because you covered some parts of the family medicine theories as well. So thank you, sir.
Thank you all for the participants in staying with us.
Yes.
Full
Okay.
participation and
Yeah, then
participation.
we
Thank you,
can
Professor.
wind this up, and good night. Good night to all.
Good night.
Thank you.